Halle Berry, the world's most famous, fittest, one of the most wealthiest person on this planet, also got misdiagnosed for perimenopause. Now, story goes that she went to the bathroom to pee, was not able to because her genitalia was inflamed, ended up in her doctor's office where she got checked, and her doctor told her that she has herpes. A few days later, she got a call that herself and her partner tested negative for herpes, and the doctor admitted that he has no clue of what's causing her symptoms. She ended up doing her own research and found out that she might be going through perimenopause. She found another specialist. When she saw him, he was not even able to utter the word menopause. She had to do that for him. And when asked why can't he just say it, he said she looked so good, so it was hard for him to say that she's going through menopause. Now, maybe in his mind, he connected menopause as a very not good looking, old, fragile person, which is a problem in itself. But the question is, if this can happen to somebody this famous, powerful, who has all the great medical care at her disposal, then where does that leave women like us, where we don't have the best doctors in the world on a speed dial on our phone? That's why it is so important that we talk about how to prevent misdiagnosis. The only thing that can save us from this mishap that's happening in this medical field related to perimenopause, menopause, is educating yourself. Now, who the hell am I? I'm Dr. Sufira Kiran. I'm a clinical lab scientist by training with over 2 decades of experience in cell and gene therapy. I'm a woman in midlife myself who had to figure this all out the hard way. Now, today I want to have a deep, very important, practical conversation about something that affects millions of us, but it's rarely named. And it's the Genitourinary Syndrome of Menopause, or GSM for short. So in this video, we are going to break down what GSM really is, why it happens, how to recognize the early signs, and the science-backed treatments available to you, both hormonal and non-hormonal. Now, before we do that, I just want to make sure that we are clear about the symptomology of perimenopause. So the symptoms that we usually hear about often are like hot flashes, night sweats, weight gain, itchy ears, changes in hair, skin, insomnia, migraines, right? So those are the symptoms, and many more. There are like so many that requires different evaluation, a different assessment for the patient, and a different treatment. So if the person is assessed by the doctor and if the patient qualifies, they can get systemic bioidentical hormone replacement therapy. And that will be by using a transdermal patch, gel, cream. It could be oral also. Now, GSM is its own little category. It relates to all the symptoms down there. So itching, burning, painful intimacy, recurrent UTIs. And sometimes you don't even have any of the symptoms. You're conscious about your genitalia. So when you're walking or sitting, you just become more aware, and this is usually because of the dryness and other changes that's happening at an atomic level that kind of create a little bit of discomfort, and that's why people become aware of their genital areas when they are having GSM symptoms. Treatment for GSM is separate than the treatment for the symptoms that I discussed that requires bioidentical hormone replacement therapy. Now, you can take both things at the same time, or you can just do one. You can just start on bioidentical hormone therapy and see if your GSM symptoms are resolved. Now, if they're resolved, then great, then you don't need a separate treatment for GSM. But if the GSM symptoms persist or they develop a little bit later, then this is something that you can look into. So the GSM is a group of symptoms that results from drop in estrogen. Everything in perimenopause happens in drop of estrogen and also progesterone. Basically, sometimes progesterone is the first hormone to drop, but we're going to focus on estrogen. So what are, again, the symptoms of GSM? Vaginal dryness, a constant feeling of irritation or rawness, discomfort during intimacy, recurring urinary tract infections, the sensation of needing to pee all the time, or worse, not being able to go when you do. Now, what's happening under the surface? As I said before, an estrogen declines, the tissue in the vaginal area and the urinary tract becomes thinner, drier, and less elastic, and more prone to tearing or infection. Your vaginal pH rises, which disrupts the healthy bacterial environment. So the vaginal pH is acidic, and that's where your normal flora, your bacteria, good bacteria kind of hangs around in that pH. And when the pH rises, become more alkaline, then your normal flora that lives there dies and get replaced by bad bacteria, and that's when you're going to start seeing recurring UTIs. And along with that, your urethra shortens, your bladder gets cranky, and your whole pelvic region feels a little different. And yet, most women have never heard the term GSM. Now, the question is uh, why people have not heard about GSM, why doctors don't talk about GSM. First, this term, genitourinary syndrome of menopause, was just coined in 2014. So it's not that long ago. Before that, it was called like atrophic vaginitis, and before that, it was called senile vagina or something really ridiculous. So there was an evolution of the terminology, or a better understanding of the symptoms, and then how to treat those symptoms. Now, this is the point of confusion for a lot of women, because you hear about bioidentical hormone therapy, brought up, but then you also hear that, GSM requires like some cream that needs to be rubbed in the vaginal area or in the surrounding structures. So if you are in a systemic therapy, why do you need a local therapy? Well, the answer is that even sometimes when you are in a systemic hormone replacement therapy, that you're taking through different modalities. I talk about the pad, gel, cream, or oral. It can still not help you with your GSM symptoms. So when that happens, when your GSM symptoms still persist or getting worse, then you have to add a medication just for that. And with GSM, this is something that will not get better on its own. Now, if you're having hot flashes and night sweats, like vasomotor symptoms, that's what they're called. If you just push through it 5, 10 years later, your body will get used to it, and those vasomotor symptoms will go away. But again, you have missed out on protecting your bones, heart, brain. You had that time period to, replace your hormones and protect those vital organs. So that has passed, which is, if you decide to do that, that's your prerogative. But your vasomotor symptoms will just go away. But for GSM, this never happens. It's not like if you push through perimenopause, get through menopause, your GSM will stabilize. It will keeps getting worse and worse and worse. And they just published a study where the difference between people who were taking medication with GSM versus people not taking medication with GSM, there was a 70% decrease in all-cause mortality in a group that was taking the treatment with GSM. That's a lot. First, I was surprised that this could be that high, but when I started reading through then it started to make sense, because when you have recurring UTIs, that bug can go into your system, and then it creates sepsis, and then you are on antibiotics, and then all the other issues, start flaring up. And if it's happening over and over again, yeah, that can kill you, especially when you are 70 and beyond. If you keep digging down and get to the root cause, for a lot of women, it could be recurring UTIs. And that's because, their tissue was so fragile, their pH was so off base that, there was no way that they can prevent from that happening. And it was not what they're eating or what their lifestyle was or how mobile or, it had nothing to do with that. It was that they have no estrogen, and it was just pure destruction down there. And it could have been solved with less than $20 a month tube of estrogen, low dose of estrogen cream. So this is why it's so painful, because the treatment is so readily available, is so cheap, and pretty much everybody qualifies for it. For systemic hormone replacement therapy, you have to go through your family history. You have to make sure that you don't have something that disqualifies you. So coming back to GSM, understanding what the symptoms are and how treatable that is. It's not, usually you hear the prices of all the medication. You're like, even if I understand, I get diagnosed, there's no way I can afford. But for this, like I said, it's less than $20 a tube per month. not even a month. I think it's last. Well, on my first, I just started last month, so it's still going. I mean, I'm not even halfway through. And you, when you talk to your doctor, depending on how severe your symptoms are, will explain to you how to start, because there's a loading dose. So it's something that you, apply every day and for 2 weeks, and then you do like once or twice a week. Your doctor will go through your regimen. So, what are the symptoms that are often misdiagnosed or dismissed? Now, if we go back to Halle Berry's story, her symptoms, which are swelling, burning, urinary retention, were so severe that her doctor thought that she had sexually transmitted infection, and he was wrong. So, these type of symptoms often get misdiagnosed as recurrent yeast infections, bacterial vaginosis, UTIs, or just psychosomatic stress. The reality is that many of these symptoms stem from hormonal tissue atrophy, not infection. Now, that's why antibiotics don't work long term, and that's why antifungal cream just make things worse. So, one stat that is mind boggling is that it is estimated that up to 80% of the postmenopausal women experience GSM, and only 10%, actually less than 10%, receive the treatment. You see the gap? The gap is huge. So, this is where, we need to educate ourselves, educate all the other women around us, and close this gap. So let's talk solutions. We're gonna look at both non-hormonal and hormonal. So you start with the non-hormonal treatment and see how that goes. If that is treating your GSM symptoms, great. Then you don't have to get a prescription. But if it's not treating, or it was treating at some point and now it's not working, then you can look into the hormonal option. Now let's break down the non-hormonal treatment first. Number one, vaginal moisturizers. So they can be used 2 to 3 times per week to hydrate the tissue long term. And you can look for hyaluronic acid based options. Number two will be lubricants. That's to reduce friction. Now try to go for pH balance and fragrance free options. Number three is pelvic floor therapy. Now, if you're experiencing again tightness, burning, just overall weird sensation, pelvic floor physical therapy can help retrain your muscles and improve blood circulation. Number four, vaginal probiotics. It can help restore healthy vaginal microbiome and reduce risk infections. Now, these were the non-hormonal treatments. Now let's look at the hormonal and prescription treatments. Number one will be the most common, which is gold standard, vaginal estrogen. And it comes in a cream form like Vagifem, or comes in a tablet forms too that can be inserted like Vagifem. There's a vaginal ring called Estring. It lasts 3 months, so it's only inserted once every 3 months. There is estrace or Premarin creams. Now, for women who don't want to use estrogen-based hormones, they have an option of using vaginal DHEA. It's called Intrarosa. Again, it's a non-estrogen hormone precursor that's converted locally into estrogen and androgens. Other options would be Osphena. It is an ospemifene. It's an oral medication that mimics estrogen's effect on vaginal tissue. It's great for women, again, who don't want to try a hormonal option. They can take this medication orally, and even though you're taking orally, the effect is not systemic. This medication seeks the receptors in vaginal tissue only. It docks there and works in the localized area. So that's one of the great options. Now, all the things that I just talked about under the hormonal category, they're all FDA approved, and it's backed by the latest 2025 guidelines. And they're shown to dramatically improve comfort, function, and overall well-being. So just be clear, low dose vaginal estrogen does not significantly raise your blood estrogen levels. Now, for most women, it's safe, even for someone with a history of hormone-sensitive cancer, though this decision should be made exclusively talking with your oncology team. All of this needs to be discussed with your doctor. The purpose of this video is just to educate you so you know what tools are available, what resources are available, and then you can go and discuss them with your doctor. Now, if any of this sounds like you're going through, please, I recommend that you make an appointment with your doctor, and you can say something like, I'm experiencing symptoms that I think might be related to GSM, and I like to discuss options like vaginal cream or DHEA. One side note about DHEA, most of the insurance, they don't cover it, so that's usually a more expensive option. Just wanted to put it out there. Now, if the doctor brush you off or say you're too young, find another provider. Seriously, just find that somebody who understands menopause, perimenopause. So your comfort, your bladder function, it all matters. And it's just not a part of getting old. It's a medical issue with a medical solution. Now, if this video spoke to you, please share it with a friend. Drop a comment if you had a similar experience. Please subscribe for more science-backed, honest health education for midlife women. Thanks for watching, and I'll see you in the next one.